In Chapter 11, we will discuss synovial fluid analysis. Synovial fluid is a viscous fluid that bathes and lubricates your joints. It's present in areas where friction can develop, such as your joints, bursae, and tendon sheaths. Your joint spaces are lined with synovial membrane composed of two types of synovial cells called synoviocytes. The predominant type is actively phagocytic and synthesizes degradation enzymes such as collagenases. The second type synthesizes hyaluronate, a mucopolysaccharide linked with 2% protein, and this adds to the viscosity of the synovial fluid. Beneath the synoviocytes is a thin layer of loose connective tissue containing a vast network of blood vessels, lymphatics, and nerves. So the picture on the left shows you the anatomy of a joint, and I want you to spend time with all the different terms and where everything is located. On the right hand side shows a picture of white cells in synovial fluid. Synovial fluid is formed by ultrafiltration of plasma across the synovial membrane and from secretions by the synoviocytes. This results in a viscous fluid that serves to lubricate the joints and a nutrient source for the metabolically active articular cartilage. The composition of synovial fluid is unique. Glucose and uric acid concentrations are the same as plasma, and this will become significant later on in our discussion. The total protein and immunoglobulin concentrations vary from 1/4 to 1/2 that of plasma. I want you to know the general classification of disease processes, and there's 4 principal categories: non-inflammatory, inflammatory, septic, and hemorrhagic. These categories can overlap, and several can occur at the same time in the same joint. Variations of test results can occur depending on the stage of disease process in the patient. The classifications used only serve as a guide. I want you to memorize the results in each of the 4 classifications of synovial fluid diseases. If you're given these results on a test, then you need to be able to pick the correct classification, as well as know the normal values in synovial fluid. Arthrocentesis is the percutaneous aspiration from a joint using aseptic technique and disposable sterile equipment. I have posted a video of an actual arthrocentesis so you can see how it's done. If possible, the patient should be fasting a minimum of 4 to 6 hours. And this is because of glucose levels. We want them to be kind of in a base state. The blood sample is collected at the same time as the arthrocentesis is done. The normal fluid volume is 0.1 to 3.5 mLs, so samples of fluid may be very small. Arthrocentesis of a joint with no fluid buildup can result in what's called a dry tap. They go ahead and do the procedure, but nothing is withdrawn from the joint. Here's an illustration of the different joint spaces that may have arthrocentesis performed on. Your book states that samples are normally collected in 3 portions. Tube 1, no anticoagulant tube for chemical and immunological studies. Tube number 2, anticoagulant tube for microscopic studies. Tube 3, sterile anticoagulant tube for microbiological studies. In my research, I could not find a reference to collecting tubes separately, and I searched extensively. The fluid is collected in a syringe and then transferred to the appropriate tubes. The best anticoagulant is sodium heparin. What is the color stopper? Green. Or liquid EDTA. What is the stopper color? Purple. Since they do not form crystals. SPS is used for microbiological studies. You want to transport the sample to the lab within 1 hour of collection and analyze it at room temperature. Testing should be performed immediately. Just like urine, you're going to observe the physical characteristics of a body fluid, and what you're going to include in your report is the total volume collected, the color of the fluid, the clarity of the fluid, and viscosity, which is not included in a urine, but is specific for synovial fluid. Each of these will be discussed in the following slides. First, we'll talk about color. Normal synovial fluid is pale yellow or colorless and clear. Red or brown are associated with trauma during collection procedure or disorders that disrupt the synovial membrane, allowing blood to enter the joint cavity. The fluid can appear greenish or purulent in some conditions, indicating infections, and milky in others, which may indicate tuberculosis, arthritis, and systemic lupus erythematosus. Clarity. There are numerous substances that can affect synovial fluid clarity, and they can be identified by microscopic examination. White blood cells, red blood cells, and synoviocytes, crystals and fat droplets, and fibrin, cellular debris, and rice bodies. And I had to look rice bodies up because it was something I wasn't familiar with. And these are white, free-floating substances made up of collagen covered by fibrinous tissue. They resemble polished, shiny grains of rice of various sizes, and they're seen in many arthritic conditions, most commonly in rheumatoid arthritis. And I wish I could have gotten the clarity of this picture better, but you can see the description. So if you're given a synovial fluid picture, I want you to be able to identify or classify the clarity of the sample. First one's normal, second one's non-inflammatory, it's clear and yellow. The next one is inflammatory. Look how cloudy that appears, full of white cells, maybe bacteria. The next one is septic, and the last one is hemorrhage, bright red blood. The presence of ochronotic shard and rice bodies may influence the clarity of the sample. Ochronotic shards have a ground pepper appearance and are present as a result of metal or plastic particles from joint prosthesis. So hip replacements, knee replacements are very, very common. Rice bodies may be present in rheumatoid arthritis or degenerated synovium enriched with fibrin. Viscosity is an important characteristic to note when observing synovial fluid. High viscosity due to high concentrations of mucoprotein hyaluronate. During inflammatory conditions, hyaluronate can be depolymerized by the enzyme hyaluronidase present in bacteria and some neutrophils. This would lead to increased viscosity. Other diseases can inhibit the production and secretion of hyaluronate by the synoviocytes. This will lead to a decreased viscosity. The viscosity, hyaluronate, and string sign will all be lost with inflammatory states. The string test is a test of the viscosity of a sample. It's kind of interesting. So there's two ways of doing it. One is to express a drop of fluid from the syringe tip that will produce a long, viscous, string-like tail, and this is called the string sign. Viscosity can be empirically evaluated by forming a string of synovial fluid between the tips of your fingers. So you put a drop on your gloved finger, put your fingers together, and then carefully and slowly have your fingers come apart. A string of 4 to 6 centimeters is considered normal. Normal synovial fluid does not clot. Spontaneous clot formation indicates abnormal presence of fibrinogen, which is a clotting factor. Pathologic processes that damage the synovial membrane can cause fibrinogen to be present. Traumatic arthrocentesis with blood contamination can also cause fibrinogen to be present, and then this will cause the sample to clot. In the laboratory analysis of synovial fluid, there's a number of testing procedures that can be done, and these will vary. Not all of these will be ordered, and perhaps additional tests will be ordered. The most common tests are the white cell count, polymorphonuclear cell count, a differential, a culture, measuring the amount of protein, lactic dehydrogenase, LDH, lactate, and crystals. Cell counts are performed using a hemocytometer. Normal saline is used as a diluent if necessary, depending on the cell count. So if you have a normal fluid with just a few white cells, it would not be relevant to dilute the sample. But if they're too numerous to count, then you need to dilute the sample, then multiply your results by the dilution factor. You may need extended time for cells to settle in the hemocytometer if the sample is very viscous. So this takes experience. But if you look and they're not settled, then you need to set the timer for a little bit more time. Hyaluronidase buffer may be used as a diluent if necessary to reduce viscosity for more efficient counting. So again, if you dilute the sample with hyaluronidase, the cell count must be multiplied by the dilution factor. Red blood cell counts are normally less than 2,000 per microliter. Increased red cells could be from a traumatic tap or hemorrhagic effusions. White blood cell count, they're normally less than 200 per microliter. When they're increased, they're typically associated with bacterial arthritis, although other conditions can also cause an increase. White blood cell counts are of limited value in identifying a specific disease process. What this means is you take this piece of the puzzle in with all the other pieces of the puzzle to classify the specific disease process. A differential cell count, cytocentrifugation, is used to concentrate the cells and preserve the morphology. Normally about 60% of the white cells are monocytes or macrophages, 30% are lymphocytes, and 10% are neutrophils. Differential counts are of limited value because they can differ not only with the disease process but also with the stage of disease. So again, we take this into consideration in the big picture in combination with other laboratory test results. If more than 80% neutrophils are present, this is associated with bacterial arthritis and urate gout. Your textbook talks about viewing a sample with polarized light, but it really doesn't go into what is polarized light. So, birefringence is something that needs to be discussed. The ability of these synovial fluid crystals to be viewed under polarized light increases the sensitivity of their detection, and polarization is an important way to do this. Crystals that are capable of polarizing light are referred to as being birefringent. This means that they have the ability to split a single beam of light into two beams, rotating 90 degrees from each other. A crystal that rotates the beam clockwise is said to have positive birefringence. A crystal that rotates the beam counterclockwise has negative birefringence. Both types of birefringence produce a white object against a black background. So this is an example of uric acid crystals in polarized light. They show negative birefringence with a yellow color when aligned with the parallel axis of the red compensator, and blue when aligned perpendicularly to it. So again, remember, two light beams are produced. Each one will show the crystal with a different color. This picture is found in your textbook. In A, this is a diagrammatic representation of monosodium urate and calcium pyrophosphate crystals when viewed using polarizing microscopy with a red compensator. The axis is indicated is that of the compensator. So the parallel is on the bottom, so we would then have blue and yellow light, but if it's horizontal, then it changes. We will have yellow and blue light. So it's really important to know what directions the axis is pointing to. In picture B, monosodium urate crystals are in joint fluid. The crystals with their longitudinal axis parallel to the red compensator plate axis, as indicated in the lower left corner, are yellow. In C, with the axis of the red compensator plate perpendicular to the longitudinal axis, the same monosodium urate crystals are blue. One of the most important tests is microscopic examination for crystals. You want to maintain the sample at room temperature and perform the examination immediately. You can use either just a simple wet preparation or a cytospin slide. Polarized microscopy should be used to identify crystals of monosodium urate, and calcium pyrophosphate dihydrate. Thorough examination by a skilled microscopist is critical. So if you're working in a body fluids department, you may spend a week or two in training prior to being able to release results on your own. I want you to know that monosodium urate crystals are present in gouty arthritis. They look like needle-like crystals with pointed ends that can distend the cytoplasm of white blood cells. In polarized microscopy, they're strongly birefringent, bright against a black background. With a red compensator plate, they appear yellow when longitudinal axes are parallel to it, and blue when perpendicular. I want you to know that calcium pyrophosphate dihydrate crystals are seen in degenerative arthritis and arthritis accompanying metabolic disease. These crystals are smaller and blunter than monosodium urate crystals. They are shaped are rod-like or rhomboid, and they display weak positive birefringence with their colors opposite of that of monosodium urate crystals. Calcium pyrophosphate dihydrate crystals with the red compensator appear blue when longitudinal axes are parallel to it and yellow when they're perpendicular. These crystals are extracted from the synovial fluid of a patient with pseudogout. Note the variation in size and morphology of the crystals and the fact that some of the particles do not appear to exhibit birefringence. They are colorless. They look like glass. This picture illustrates the difference in polarization between calcium pyrophosphate dihydrate crystals, which are in B, and monosodium urate crystals, which is in the A picture. And the arrow indicates the axis of the gypsum plate that these are portrayed through. C and D indicate the birefringence when the axis is changed. These are cholesterol crystals observed on a wet preparation or an unstained cytospin. They're flat, rectangular plates with notched corners, and they're seen in chronic inflammation. And the picture on the right shows them polarized. As I did my research on hydroxyapatite crystals, I found that they're not routinely seen and may only be identified by electron microscopy or by staining with alizarin red. So I was kind of puzzled why this was included in your textbook because it's not very commonly seen. They're observed in electron microscopy intracellularly as tiny needle-like crystals. And basic calcium phosphate crystals encompass 3 different types of calcium crystals: carbonate substituted hydroxyapatite, ostocalcium phosphate, and tricalcium phosphate. Hydroxyapatite is the most common component of a BCP crystal. BCP crystals are usually inert and asymptomatic but can cause several syndromes due to deposition in and around the joints and soft tissues. They have been identified in synovial fluids for many conditions, particularly in apatite-associated destructive arthropathy, osteoarthritis, and calcium pyrophosphate arthropathy. These can induce an acute inflammatory reaction similar to those caused by MSU and CPPD crystals. I looked and looked and looked, and I could not find an electron microscope photo. So what I did find was the morphology under compensated polarized light microscopy and a special stain of a BCP crystal. So HA or BCP crystals present with amorphic features in the picture A and shows no birefringence under compensated polarized microscopy. In the right-hand picture B, alizarin red stain of HA or BCP staining orange or red color. And look as I might, I could not see needle-like structures, but this is just what you need to know about these crystals. Corticosteroid injections are frequently given in joints to reduce inflammation, and these produce crystals which can be seen for months after the injection. They're of no clinical significance, but they may be mixed up and misinterpreted for MSU or CPPD crystals, but yield conflicting results based on their birefringence. This is a picture from your textbook, synovial fluid with corticosteroid drug crystals present, and note their conflicting morphology. It suggests calcium pyrophosphate dihydrate and strong negative birefringence, which suggests monosodium urate. Wet preparations when unstained, and then polarizing microscopy in picture A, many strongly birefringent drug crystals that morphologically resemble CPPD using polarizing microscopy. In B, drug crystals with their long axes parallel to the axis of the rep compensator relay are yellow, suggesting MSU crystals. We'll now move on to the chemical examination of synovial fluid. Although numerous chemical constituents in synovial fluid can be analyzed, few analytes provide diagnostically useful information. Uric acid is present in the same concentrations in blood and fluid, so these are usually monitored using a blood sample. Other analytes can differ and aid in the differentiation of joint disease. Cholesterol and triglyceride measurements are of limited clinical value and rarely done. For glucose, the blood sample must be drawn at the same time as collection of the synovial fluid, and we prefer that the patient be fasting. Blood and glucose samples should have a difference of only 10 milligrams per deciliter in fasting patients. Total protein concentrations of synovial fluid is approximately 1/3 the protein concentration of blood plasma, so the blood plasma should be tested for protein as well as the synovial fluid, and a comparison is done. Increased levels occur from changes in the permeability of the synovial membrane or from increased synthesis. Increased protein levels may be a result of a variety of joint diseases such as rheumatoid arthritis, crystal synovitis, and septic arthritis. However, results do not assist in differential diagnosis of joint disease. It only indicates an inflammatory process is going on. So as I've said before, these results are used in conjunction with other results to give the big picture and come to a conclusion as to the cause of the joint disease. Normal synovial fluid levels of uric acid will be the same as plasma. So normally plasma is used to monitor patients with high levels of uric acid. Increased levels along with symptoms point to a diagnosis of gout. So what is gout? This is a common form of inflammatory arthritis that is very, very painful. It usually affects one joint at a time, and usually it's the big toe joint. Not all patients with gout will have increased levels of uric acid. Increased levels in fluid may cause the production of monosodium urate crystals. Just for your information, I wanted to show you a patient with gout, and it's very common, and I've known a lot of people who have gout, and there's 4 different stages, and so you can review this slide on your own. Lactate is increased due to anaerobic glycolysis in the synovium. With severe inflammatory conditions comes an increased demand for energy, and tissue hypoxia can occur. Some conditions of the joint, particularly septic arthritis, have been associated with significantly increased synovial fluid lactate levels. In contrast, gonococcal arthritis presents with normal or low lactate levels. Clinical value has not yet been established. Lactate dehydrogenase or LDH levels are not mentioned in your textbook, but as I did my research in a lot of different publications, they showed LDH as a frequently ordered test on synovial fluid. Lactate, lactic acid, and lactate dehydrogenase, LDH, determination in synovial fluid, especially lactate, are being considered as significant tests to differentiate between septic arthritis and other forms of arthritis. Elevated lactate and LDH levels in the study were corresponded with bacterial culture outcomes that manifested the growth of Pseudomonas aeruginosa, Staphylococcus aureus, and Enterococci species. The LDH activity of the synovial fluid was elevated in patients with rheumatoid arthritis, infectious arthritis, and gout, but normal in the fluids of patients with degenerative disease. A gram stain aids in the differential diagnosis of joint disease. The gram stain method is one of the most commonly used methods to rapidly identify the cause of bacterial infections. When the gram stains are positive for microorganisms, they provide immediate useful diagnostic information. All synovial fluid samples should be cultured, and they need to perform a routine aerobic and anaerobic culture. Most infectious agents are bacterial and come from the blood. Other agents include fungi, viruses such as HIV, and mycobacteria. The sensitivity of the gram stain depends on the organism. 75% of patients with staphylococcal infections identified as positive by gram stain. 50% of gram-negative organisms, which may include E. coli, Proteus, Klebsiella, and Enterobacter, and 40% of Neisseria gonorrhea infections. The results of the culture are critically important for prognosis. Acute non-gonococcal septic arthritis is a medical emergency that can lead to significant morbidity and mortality. And morbidity are the consequences of an infection, such as damage to tissues, and mortality is you die. Prompt recognition, rapid and aggressive antimicrobial therapy, and surgical treatments are critical to ensuring a good prognosis. But even with prompt diagnosis and treatment, high mortality and morbidity rates still occur. In contrast, gonococcal arthritis is often successfully treated with antimicrobial therapy alone and demonstrates a very low rate of complications and an excellent prognosis for full return of normal joint function. In the case of prosthetic joint infections, the hardware must be eventually removed by a two-stage revision in order to cure the infection. In the laboratory, we use a lot of flowcharts. If this, then that, then that. So this is an overview of synovial fluid testing, and is for your information only, but I would encourage you to spend some time reviewing this. And if your questions are not answered, bring them to your instructor.